Hi everyone, my name is Caitlin Martin. Thank you so much for this opportunity to speak with you today. I'm going to be speaking about opioid and substance use disorders, particularly in women across the life course. A little bit about myself. I am a general obstetrician gynecologist and I work at Virginia Commonwealth University here in Richmond, Virginia. I'm also an addiction medicine provider. Clinically, I wear a few hats. Clinically, I am the Director of OBGYN Addiction Services here at VCU. What I do here is I work on integrating reproductive and sexual health services, along with addiction treatment services here across our medical campus. Within doing that, we work clinically, mainly leading our clinic for pregnant and parenting women with substance use disorders, where we're the only clinic in our area that provides integrated substance use treatment and reproductive sexual health services all in one clinic, along with wraparound services, including social work, etc. I'm also a physician scientist, so my research all is focused on that area of intersection between women's health and also substance use treatment. I've particularly focused on opioid use disorder in the postpartum state, as well as sex and gender, how that is incorporated into substance use treatment practices going forward to better individualize and personalize treatments for people seeking recovery from the disease of addiction. These are my disclosures. So just to kind of get started, some of the main points I'm going to be going over today is that addiction is a chronic brain disease of neurobiological basis that's affected by complexities in our environment. We're also going to talk about some treatments and medications for substance use disorders, just given my clinical background as a physician who treats people with addiction. And we're also going to focus on how treatment and medications work really well for a good cohort of people who need them to help seek recovery. But they only work if people have access to these medications and treatments, and people don't perceive being judged for taking and using them. Again, we're going to focus on addiction within a chronic disease model and how we really should be treating it just like we do for diabetes and hypertension in that manner, but with multiple complexities given the behavioral aspect to addiction. And then lastly, we're going to be focusing on how the goal of treatment is not abstinence, it's not cessation of substance use. That is only one part of the puzzle, and how it's recovery. And recovery includes multiple things. So to kind of take a step back and go over some of the epidemiology that I'm going to be focusing on today is that substance use and the opioid crisis are increasingly harming women disproportionately more than they are for men. This is a Pinnacle paper that came out last year looking at the life expectancy in the United States and how unfortunately over the recent years it has decreased despite all the gains that we've had over the past decades with regards to increasing life expectancy due to advances in medical technologies and other social supports. A big driver of this decrease in life expectancy has been contributed to the opioid overdose epidemic, namely the increasing mortality rates due to opioid and other substance use, largely among reproductive age people. What's interesting in this paper, unfortunately though, is that when they looked at the data and they stratified it by sex, so between males and females, they found, quote, a pronounced female disadvantage that emerged for certain major causes of death. In particularly, these causes of death were those related to drug and alcohol use. So what we've noticed, again, with CDC data is that opioid overdose deaths over the last decade have been increasing, and they've been, even though more men do die from an opioid overdose every day than women, the rate of increase over time has been much more rapid for women than it has been for men. And what's really important to remember is that women are women, and a big part of the life course for many women, but not all, is the pregnancy and postpartum periods. And so unfortunately, these sad epidemiologic trends that have noticed that women are being disproportionately affected by the opioid overdose crisis extends into pregnancy and the postpartum period. We've had data that has come out from certain state mortality boards, for example. This is one from Colorado that looked at deaths from 2004 to 2012 among women during pregnancy and the postpartum period, defined as 12 months after birth. And what they found was that unfortunately, deaths related to behavioral health causes, in particular suicide and drug-induced deaths, had exceeded all the traditional causes of death that we typically know and that I was trained in as an OBGYN: postpartum hemorrhage, preeclampsia, hypertensive diseases of pregnancy, etc. And for the deaths that had toxicology data, we also noticed that the number one substance that was present in these deaths right here were opioids. But what's very important too to notice from this data here is that it wasn't just opioids, it was other substances too. And so on that note, I'm going to be talking a lot about opioids today just because that is what I typically treat here in Richmond, Virginia. Substance use is very geographically focused, and so a lot of my patients are in treatment for opioid use disorder, and that's what a lot of the data has been coming out on. But opioids are just one part of the problem. We have to remember that opioids are just one substance, and substance use disorders, they include multiple substances. They can be alcohol, cannabis, other substances such as cocaine and amphetamines. And so even though, again, I'll be focusing on opioids today and a lot of my examples about substance use disorders and how they disproportionately affect women and how we need to tailor our approaches to recovery in a gender-informed way, we need to make sure that we're not just focusing on the opioid, but we're focusing on all substance use and how we target these trends and how these efforts on a public health basis. So again, to take another step back, and this might be a little bit of a review for many people in the audience, but we're going to be going over a little bit about what is addiction, what is a substance use disorder, again, taking that neurobiological basis and kind of blowing it up. And the reason I'll be doing that, even though that's maybe a review for some people in the audience, is that is how I'm going to discuss some of the medications that we do treat for opioid use disorder in particular. So first is that not everyone who uses drugs or alcohol develops substance use disorder. This is a very, seems like a very simple fact, but some people forget this sometimes. And when we're thinking about addiction and how to tailor our public health strategies and treatment strategies for people, we need to remember this. So current drug use is common. This is a lot of the data I'll be presenting in my presentation today comes from the National Survey on Drug Use and Health. That's the annual survey that's done every year by SAMHSA, the Substance Abuse and Mental Health Services Administration. It's essentially the big data that comes out nationally that says X number of people have depression, Y number of people with depression are getting treatment. And they're the numbers that drive a lot of the public health approaches and how we also tailor our research priorities too. And so not everyone who uses those substances that we just saw in the last slide develop a substance use disorder. This is one example. This is from the 2016 NSDA data. It's a little dated, but generally the point gets across even if it was the most updated data. This is just looking at women in particular. And what we looked at in the self-reported data is the best we have for substance use on a national scale. 15% of people reported any type of illicit drug use. 8% of those were people who reported use of an illicit drug other than cannabis. But when you actually looked to see how many of these people actually had met criteria for a substance use disorder, okay, so using a substance is different from having a substance use disorder or having an addiction to that substance, only 2% of people met that criteria. And that is defined by the DSM criteria that we use as providers to diagnose someone with the disease of addiction. You can see here that it's the same for opioids. You can see that 36% of people use prescription opioids. That's not surprising, right? Given that opioid is a very common medication we use for pain, maybe after a surgery, but less than 1% of people met criteria for an opioid use disorder. And the same we can see here for alcohol. So what makes those two columns different? What makes people different between people that use a substance and then people who have a substance use disorder? Now, I'm not a psychiatrist, I'm not a neurologist, I am an OBGYN, but how I like to discuss what a substance use disorder is to my trainees and also to my patients, I kind of think of it in these three general bubbles. Not every person who has a substance use disorder will kind of follow this chronological arena that I'll be discussing today, but it is an easy, good example to think about what is addiction from a diagnostic criteria. So the first bubble that we think about that drives into a substance use disorder is physiologic dependence. So to give an example, I broke my knee and I had surgery. My doctor prescribed to me oxycodone, which is a short-acting opioid, 10 milligrams 3 times a day. I took that medication for quite some time. I maybe had some complications in my post-operative course. My knee didn't get better for a long time. So I ended up being on this oxycodone for many months. My knee eventually got better. And then when I went to go taper myself off of the oxycodone, I had withdrawal symptoms. I maybe had some cravings. I just overall did not feel well because I was stopping that medication. That was a sign of my body being physiologically dependent on that substance. I can say that I am actually physiologically dependent on caffeine, for example. My husband would definitely tell you that when I miss my coffee in the morning, I just don't feel well, and I'm maybe not a very nice person. The other bubble that leads into a substance use disorder diagnosis is going to be misuse. So to go back to my example, I broke my knee, I had a rough post-operative course, I was on oxycodone 10 milligrams 3 times a day for quite some time. I tried to come off of it, but I felt ill, I was having withdrawal symptoms because my body was physiologically dependent on that substance. In the setting of feeling ill from those withdrawal symptoms, I went back to using oxycodone. I maybe took some from my family members, I maybe bought some from a drug dealer off the street, I maybe started using more than I was prescribed, despite me telling my provider that I was using 10 milligrams 3 times a day. Maybe I was using 20 milligrams 4 times a day. I started storing my medication. I started using it in ways that I was not prescribed to do so. That is misuse of a substance. That example applies most appropriately to prescription opioids or prescription substances. The last bubble becomes the pinnacle of substance use disorder. You cannot give someone the diagnosis of addiction or a substance use disorder unless they have what we call maladaptive behavior or continued use of the substance despite adverse consequences. So to go back to my example, I use oxycodone 3 times a day as prescribed by my doctor, 10 milligrams. I tried to come off of it. I felt very ill from withdrawal symptoms. I started misusing the medication in the setting of those withdrawal symptoms. I started snorting the medication, using more than I was prescribed. And then I noticed that my use of the oxycodone my misuse of the oxycodone using more than prescribed, snorting, etc., was leading to getting in the way of my relationships with my family, me not being able to take care of my children. Maybe I lost my job. Maybe I had some legal problems. But despite having all those issues related to my use of the opioid, I continued using it. So I continued using that substance despite the adverse consequences. That is the pinnacle of addiction. That is what leads to someone having a diagnosis of a substance use disorder. And that is when we need to assess patients and see what we can do from a treatment perspective to help them with this disease. So why do some people develop that third column? Why do some people start to continue to use substances despite adverse consequences? Whereas other people, if it started getting in the way of their quality of life, they would stop it, right? Well, that is because addiction or a substance use disorder, which is one type of addiction, is a chronic disease of the brain. It's not a moral failure or simply a choice. What's important to remember is that addiction has a neurobiological basis. There's robust research on this. And that what's interesting is that addiction is a brain-centered condition whose symptoms are behaviors. Why this is important, and why I just kind of keep on pointing this out multiple times, is that even though I say addiction is a chronic disease like diabetes, hypertension, which is true because those are also chronic diseases, what makes addiction different though is that its symptoms are behaviors. It's not a number, it's not a lab test. So if I have hypertension or high blood pressure, I go to the doctor, I have a blood pressure taken that has numbers. I can track those numbers over time, and that is how I also diagnose someone with hypertension, is by those numbers on the blood pressure. It's not like diabetes and the fact that addiction symptoms are behaviors. For diabetes, I can diagnose someone with diabetes based on their sugar log, based on a hemoglobin A1C lab test, again, numbers. Whereas addiction is also a chronic disease, just like diabetes and hypertension, but its symptoms are behaviors. And that is likely why, as providers, sometimes it can be a little bit harder to teach people how to diagnose addiction, manage it, etc., because behaviors just end up being a little bit more subjective than numbers from a blood pressure or from a hemoglobin A1C. And again, the salient feature when we're looking at the disease of addiction is that its symptoms are behaviors, namely behaviors of continued use of a substance despite adverse consequences. So this is the formal definition of addiction here, is that addiction is a treatable chronic medical disease that involves complex interactions among brain circuits, genetics, environment, and an individual's life experiences. And the American Society of Addiction Medicine has updated their definition of addiction recently to include this last sentence here, that prevention efforts and treatment approaches for addiction are generally as successful as those for other chronic diseases, which brings me to the basis of what I've been discussing thus far. So what is this neurobiological basis that I keep on talking about, or these brain circuits, and the fact that the addiction is a chronic brain disease? Well, let's take a step back and talk about a little bit about what addiction, what substance use does to the brain. So when you use a substance, such this example here is cocaine, what happens is that you get high level surges of these things called neurotransmitters in your brain. One of the most common neurotransmitters that we talk about is dopamine. So when I use a substance over and over again, my brain has surges of super high levels of these neurotransmitters, such as dopamine. Dopamine is that neurotransmitter that makes you feel good. It makes you feel warm and fuzzy on the inside. Dopamine is also that thing that increases when you're doing things that do bring you joy. For me, that's like walking my dog, eating a piece of chocolate, spending time with my family. All those positive life things that you have that help you feel warm and fuzzy on the inside, that is your dopamine, for example, increasing in your brain. So our brain is meant to have higher levels of dopamine at certain times in our life. That is how we bond with different people. We feel happiness when we're with our children, for example. But when someone uses substances, it leads to really high levels of dopamine in the brain, really, really super physiologic high levels, to the point where we're not supposed to have those high levels of dopamine in the brain. Our brain is not meant to have such high levels of dopamine in our brain, especially when it's going up and down over time. So what happens over time is that with these repeated, very high levels of dopamine going up and down, up and down, higher than our brain is meant to handle, your brain starts to change. Your brain starts to change in multiple ways. The brain structure starts to change. Your dopamine receptors start to change. Your brain starts to look different, and your brain starts to function in a different way. And it leads to what we call is being hijacked. Your brain becomes hijacked by dopamine. So what happens is that over time, with all these changes in the circuits and the dopamine receptors, even in the structure of the brain, between the front of the brain where it tells you what is a good thing to do, what is a bad thing to do, and the other parts of the brain that tell you how, when you're happy or when you're sad, those connections between the brain change to the point where your brain constantly needs those levels of dopamine. Not the normal levels of dopamine that we're meant to have, the warm and fuzziness that I have when I'm with my children, for example. Your brain gets to the point where it always needs those really high levels of dopamine that it's only experienced when it was using that substance, such as the cocaine on the prior slide that I showed you. And your brain becomes hijacked by that need. So your brain constantly needs those really high levels of dopamine, but you can't get those levels of dopamine with normal things. You can only get it with the substance. So that leads to your brain telling you, you need to go get that substance. You need to go get that substance. I need to have those really high levels of dopamine to feel normal. And what happens is that your brain then starts telling you, oh, it's okay to go do that thing, to have that adverse consequence, okay? Because it's worth it, because you're going to be able to get that substance. And your brain starts doing those things. You start having those cravings for the drug, and that's what leads to the disease of addiction. And we've seen with fancy fMRI studies that have been done over many studies, we've seen these changes in the brain that can happen with continued exposure to these substances. And so we've seen these changes in the dopamine receptors. We've seen the changes in the brain structure that lead to people constantly needing to have those super physiologic levels of dopamine, despite them only being able to have those high levels of dopamine with the substance that comes with adverse consequences in many circumstances. And on the flip side, what happens when someone gets to this point of their brain malfunctioning is that people, when they're not having those high levels of dopamine, when they're not using that substance that gets them to that point, what that their brain is asking to have, okay, with regards to the levels of dopamine, they feel sick. And so what happens is that people eventually become unable to feel the warm and fuzziness that they used to feel with the normal things in life. Being with their children, eating a piece of chocolate, walking their dog. They're no longer even able to have that happiness or that euphoria with things that cause those normal levels of dopamine. They can only feel normal with those super high levels of dopamine that only come with using the substance. And when they're not using that substance, they feel sick. They have those withdrawal symptoms. They feel depressed. And when they do use that substance, they actually no longer feel that euphoria anymore. They get to the point where they just feel normal. So, kind of going off of that kind of depressing explanation of addiction, why do some people develop this terrible disease and why do other people not develop this terrible disease of the brain? Well, there are many people that are spending their whole lives trying to figure that out, and it's very complex. It involves interactions between genes, biology, DNA, one's environment, the drug itself, and multiple other vulnerabilities. What is important to remember when we're thinking about sex and gender differences in addiction is that many of the risk factors in this complicated complexities between vulnerabilities for addiction are more common in women than in men. So women typically have more psychiatric comorbidities, which we know are risk factors for the disease of addiction. Women are more commonly going to have trauma histories and more significant trauma histories, such as those related to intimate partner violence or interpersonal violence. And women also are more at risk of having lower social support, particularly when we're talking about parenting women. One particular vulnerability that is more significant in women than in men is adverse childhood life experiences, or ACEs. You can go online, you can take the ACEs quiz to determine what your ACE score is. But the point of this slide is to say that women have had more ACEs than men. They've had more adverse childhood life experiences than men. And the research has shown that there is a dose-response relationship with regards to the association between one's ACE score and the risk of having or developing the disease of addiction. The higher your ACE score, the more at risk you are of developing addiction. So therefore, you put those two things together, women are more commonly going to have ACE scores and going to have higher ACE scores than men, and a higher ACE score is associated with a higher risk of addiction. And those two things cross, unfortunately, to lead women to be at more risk of not only having a substance use disorder in some studies, depending on the substance, but more commonly, women are more likely to have worsening psychosocial functioning and morbidity due to substance use disorders than men. So again, kind of going back to the end of what I talked about before, about addiction within the chronic disease model, now let's focus on a little bit of pregnancy, okay? I can't hold myself back, given that I am an OBGYN, and a big part of my clinical practice is treating people with the disease of addiction during the peripartum or pregnancy and postpartum periods. First, I just want to take a step back and say, women during pregnancy, pregnancy is one point of life, one point along a woman's life course. If any of you have been pregnant before, you know that once you are pregnant and during that pregnancy period, it's not like you become a whole different person, okay? It's not like your whole, your mind changes. Your body definitely changes a lot with pregnancy. But it's not like overnight you become pregnant, oh, all your problems are gone. Oh, that chronic disease has gone away. And I think a lot of people forget that. When women have diabetes or they have hypertension, when they get pregnant, we have to increase our support for those women, increase their surveillance for those women, because it can come with complications of pregnancy. We don't expect their hypertension or diabetes to just go away because they got pregnant. Addiction is no exception to that rule, because pregnancy is just one point along the woman's life course. For many women, addiction does continue through pregnancy and the postpartum period because of that. But what typically happens when we're talking about substance use with pregnancy? Well, when we look at just substance use, not substance use disorder, in general, when women get pregnant, they decrease or stop using substances, alcohol, tobacco, other drugs. That is a common thing that we know. So, and that is because all pregnant women are motivated to maximize the health, their own health, and that of their baby to be. So, when women are pregnant and they continue using substances that adversely affect their health, they likely have a substance use disorder. And so therefore, when people continue using substances in pregnancy, that's drugs, alcohol, and also tobacco or nicotine, that is generally pathognomonic for the disease of addiction. And that means that we need to increase our support and our surveillance of these women during pregnancy, just like we do for women with other chronic diseases. So what is this increased support that I keep on talking about? Addiction's a disease, we need to address it even during pregnancy. Well, the good thing is that we have evidence-based treatments for the disease of addiction. We do, and they are effective. And again, but they're only effective when we give them to women, we give them to people, and we do not judge people for using them. And most importantly, we tailor them to an individual's needs. So when we're talking about tailoring substance use treatment, it is quite a little more complicated sometimes than other chronic diseases because of the multifactorial nature that addiction has. So you remember that prior slide I showed you with all the risk factors and those complicated arrows between the risk factors for the disease of addiction that lead to someone being vulnerable to developing addiction? Well, we need to also tailor our treatment for people who are entering treatment to seek recovery from addiction the same way. Why would we do them differently? That makes no sense. So just like the vulnerabilities to addiction are very complicated and come from multiple different aspects, we also need to tailor treatments the same way. They come from multiple different areas. And what that leads to is multidisciplinary treatment, multimodal treatment, and most importantly, individualizing treatment regimens to an individual's needs. And what we think about is when we have addiction treatment, we need to consider all of these bubbles on this slide here, multiple different things. But not everyone's going to need all of these things, right? Not everyone is going to need dedicated mental health services. Not everyone is going to need transportation help, etc. And not everyone is going to even need medications. Many women with opioid use disorder do gain a lot of benefits from medications for opioid use disorder. But what's important to notice here, it's just one piece of the puzzle. And this is how I do it here at BCU with our program for pregnant and parenting women called the OB Motivate Clinic. We work on striving for this quality of care. We work on offering all of these wraparound services for my patients within an integrated service model, which includes not only prenatal and postpartum care, but also medications when indicated, such as those for opioid use disorder. So like I mentioned at the very beginning, I am going to focus a little bit on opioid use disorder and on medications, just given that that is one hot topic these days. So a good thing to know is that you don't have to remember everything I'm telling you today. Everything is that I'm going to talk to you today with regards to opioid use disorder and pregnancy, postpartum, and infants is in this lovely document here, the SAMHSA document, which is free online and very easily searchable too. But I'm going to go over some of the highlights from this document and some of the data to support it as we're thinking about how to tailor opioid use disorder treatment regimens for pregnant and parenting women. The first highlighted recommendation from this document, from the SAMHSA guidelines, is the need for a collaborative approach to treatment. And why is that? Why do we strive for that prior slide with all the bubbles and those wraparound services in addition to the medication and other medical services? Well, for pregnant people, we've had robust research over time that shows when women with the disease of addiction receive prenatal care and they receive addiction treatment, their outcomes for themselves and for their children end up being pretty similar to people without addiction. Just one example, this is one of the first papers that was studied by that was published by Loretta Finnegan in 1978. Looking at just one outcome, just one common outcome we look at, there's multiple others, of low birth weight. And they looked at the women with a substance use disorder who got care and who didn't get care. You can see here that the rate of low birth weight in the women with substance use disorders who did not get care during pregnancy, unfortunately, was quite high. But then when you look at the rate among women who had a substance use disorder and did get care, the rate was actually really similar to the control group or the comparison group of people who did not have a substance use disorder who got prenatal care. So we need to remember that when we are offering women compassionate, person-centered care, especially during pregnancy and the postpartum period, you are helping to support the health of a family for a lifetime. The second highlighted recommendation from this document that I'm going to focus on today is that medically supervised withdrawal, or quote detox, is not recommended during pregnancy. And so this has been reiterated in multiple different fashions, multiple systematic reviews and guidelines, and this is just one example here from the WHO. is that women who have an opioid use disorder, they should be offered medications for opioid use disorder. We're going to focus on those, such as methadone and buprenorphine. And they should be supported in continuing those medications for as long as they need to, or as long as they desire to be on those medications. And that is in line with robust research among pregnant and non-pregnant people showing that the longer someone stays on medication for opioid use disorder, if they were on, did help them. And that's not true for every patient, many patients it is. The longer you stay on medication, the better your outcomes are long term. And then we're going to spend a bulk of our discussion from this document on what these medications are and talking a little bit more about them. So what are these medications I keep on talking about for opioid use disorder? Well, there are 3 FDA-approved medications for opioid use disorder. To give you a little bit of background about how these medications work, is that they work primarily on what's called the mu-opioid receptor. So this is a graph here looking at the y-axis is the effect on the mu-opioid receptor. So that's a receptor that's in our nervous system when you take opioids that help you with pain. Okay, for example, this is the same receptor that those opioids, such as oxycodone, that people use for post-op pain. It's the same receptor that these medications work on too. And then the y-axis here is the dose. But what's interesting is that these 3 medications work in a different ways at the mu-opioid receptor, and they all have positive attributes to them that decrease the risk of abuse of the medication or misuse of the medication. They're long-acting, and because they're long-acting and not short-acting, they can reduce the risk of misuse, and then also help people achieve stability. So these are medications, they are not substituting one drug for another. Because of the way they work, that's quite different from short-acting opioids that can be misused, such as oxycodone, etc., as well as illicit opioids, such as heroin. So the 3 medications are methadone. Methadone is a full agonist of the mu-opioid receptor. And so as you increase the dose of it, you do get more of an effect of the medication on that receptor. But because of its long half-life, it is much less likely to be misused or abused when it's taken as prescribed. Methadone is typically dispensed at a methadone clinic, so clinics that are regulated and that dispense methadone on generally a daily basis. So patients generally have to go to and from the clinic every day, except for in some circumstances where they can get take-home medications to receive the methadone, and it is dosed on a daily basis because of that long half-life. Buprenorphine is a newer medication for opioid use disorder. The brand names are called Subutex or Suboxone. Suboxone is generally what is preferred both during pregnancy as well as outside pregnancy. It is a combination of buprenorphine and naloxone. That's why it's called Suboxone. Naloxone is the same thing that's in Narcan. So that is an antagonist of the mu-opioid receptor. The reason why they're both combined in Suboxone, and this is the preferred formulation that we give people with opioid use disorder, is because it helps prevent diversion and risk of adverse consequences if someone were to use it who were opioid naive. So for example, if this was on the street, someone was opioid naive, they crushed it and injected it, they wouldn't die from an overdose from the buprenorphine itself because the naloxone becomes bioavailable at that time. But when you take the Suboxone as prescribed, which is sublingually underneath the tongue, that naloxone component is not bioavailable. It does not work. It's only there in the risk of the diversion example that I gave earlier. And so a lot of patients think that the naloxone is getting in the way of it working well. That's actually not true. It's really not bioavailable very well when it's taken sublingually. But because of that, it helps protect from that risk of diversion and morbidity from that. This is the preferred formulation. Buprenorphine, which is the active ingredient in Suboxone, is a partial agonist of the mu-opioid receptor. So you see here, as you increase the dose of the medication, okay, the effect of the mu-opioid receptor starts to level off. It has a ceiling effect. And that is quite useful because as you increase the dose, you might not have as many of the increased side effects that you sometimes get, for example, with methadone. But what's also important to remember is that once you get to this point right here, this is where you want patients to be. You want them to feel normal. But taking more won't necessarily make you feel more normal. And then lastly, the last medication is naltrexone, or the brand name is Vivitrol. Naltrexone can come in a daily dose taken by mouth, but more commonly is given as an injectable once monthly. And naloxone is an antagonist naloxone and naltrexone are both antagonists in the opioid receptor, which means they block the receptor. And that is how they primarily work. What's important to remember is that all of these medications are medications. They are based in neuroscience. There is robust research that was done, and they are not a replacement for drugs. So, of course, you can abuse and you can misuse anything. I'm an addiction doctor. I see that all the time. People can abuse or misuse any type of substance or prescribed medication. But when you take these medications as prescribed, they are medications. We do not, and so people a lot of times are judged for taking these medications. They're saying they're replacing one drug for another. We don't say that to people who are on insulin for diabetes. We don't say that they're just replacing a sugary donut for insulin. We should not be saying those types of stigmatizing statements to patients who are on medications for opioid use disorder, because they are based in that neuroscience that I discussed with you at the beginning of my presentation to help people feel stabilized over time and help them reach recovery. So again, when medications are dosed correctly, either buprenorphine or methadone, for example, during pregnancy, which are our preferred medications currently during pregnancy, you lead to this physiologic dependence being stabilized. So patients should no longer feel cravings or withdrawal symptoms when they're at the proper dose of their medication for opioid use disorder. When patients feel stabilized from that physiologic dependence standpoint, okay, so they don't have cravings, they don't have withdrawal, but at the same time, the way that they're used as prescribed, they can't feel those euphoric effects, okay? Because when someone's taking this as prescribed, because of the long half-life, and then for buprenorphine, that ceiling effect, you don't feel that euphoria, that quote high with the medications versus what you can feel with heroin. So that leads to less misuse of substances once people are stabilized on their medication. And all in all, when you take care of these two things, okay, that I just discussed, you can help people not continue to use substances despite adverse consequences. And how I like to discuss it with my patients is that medications for opioid use disorder give patients a platform for recovery. It's really hard to go engage in groups, take parenting classes, go spend time with your kids, whatever that thing is that my patient wants to achieve in recovery. It's really hard to do those things when you are just thinking about drugs all the time, when you're having those cravings, or when you're having withdrawal symptoms, or you're having legal problems due to your drug use. It's really hard to go out and do those things and get mental health support, get treatment for your psychiatric comorbidities, etc. And so these medications can really help give patients that stable foundation for them to go then be able to do all the things that are going to help them reach their goals of recovery. So in summary, when someone is on the pathway toward the disease of addiction, when they use substances at the very beginning, they feel those highs, okay, those quote highs, like with heroin, cocaine, etc. Then they feel normal, high, normal, high, normal. Over time, because of the changes that happen in the brain with regards to that dopamine hijacked hypothesis that I discussed earlier, people get to the point where when they use drugs, they're only using drugs to feel normal, to be here in the middle. And when they're not using drugs, they're feeling sick. They're having those withdrawal symptoms. And so people then continue to use the drugs in order to feel normal. And they no longer are able to feel that euphoria anymore. And so for opioid use disorder, when people are taking these medications as prescribed, buprenorphine and methadone, for example, they feel normal. They stay right here in the middle. They don't feel the high and they don't feel the low. And this is where I want my patients to be, because this is where they're going to be able to achieve all their recovery goals. And what's really amazing and what I really like to discuss with my patients ad nauseum is that their brains can heal. So once someone reaches recovery and they stay in recovery, even if that's with medications, such as those for opioid use disorder, their brains can heal. Now, it takes a long time, as I discussed with my patient. It can take years, but their brains can go back to healing. And that is a very powerful thing. I can't tell patients all the time in medicine that I can help them heal from their disease, but I can tell my patients that I can help them heal from the disease of addiction. A couple things I'm going to mention with regards to opioid use disorder in pregnancy is the effect on the growing infant or the fetus. And so what's important, we're going to go over what is called neonatal opioid withdrawal syndrome, or NOWS, or NAS. NAS is the physiologic manifestation of what happens when an infant that after an infant is born, when it was exposed to opioids in the uterus, that it can have withdrawal symptoms after it's born because it's no longer being exposed to those opioids anymore, even if that's with a prescribed medication like methadone or buprenorphine. What is very important to remember is that NOWS or NAS is not addiction. If you remember, you should know that by now because we've gone over multiple times that addiction is a chronic disease. It is physiologically impossible for an infant to have a chronic disease because they were just born. They cannot have a chronic disease at birth. And so addiction, remember, it has to have those continued use of a substance despite adverse consequences. Infants are not able to do that. But what NAS or NOWS is that it is withdrawal symptoms. It is when infants, because they were exposed to an opioid, can have withdrawal symptoms for a temporary period of time. Just as with if a patient was using opioids on a chronic basis and stopped those opioids, an adult patient would also have withdrawal symptoms too. It's very similar concept. But adults and infants are different. So when my patients are using opioids, even if it's a prescribed opioid and they stop it, they will have those withdrawal symptoms, the chills, the sweats, the nausea, etc. Infants can also have their own version of those symptoms, as you can see here on this slide. It just looks different because they're babies instead of adults. What's important to remember is that NOWS or NAS is a temporary condition. It is a temporary condition that we do have treatments for. And just like when we talk about infants that are exposed to opioids, and we need to remember that they are at risk of the exposure and of course to the dependence that they can develop and to the temporary condition of withdrawal, we need to also remember that medications for opioid use disorder can also help families stay in recovery long-term, and that is even more important, I would argue. There's been multiple papers that have come out looking at the effect of NAS or opioid or NOWS on infants' long-term health. Currently, according to the research that we have today, NAS or the withdrawal itself that can happen from the exposure to opioids in utero is not associated with any long-term deleterious consequences. What is associated with deleterious consequences for families is untreated addiction. And so what is the most important for my patients to remember is that a healthy living environment, a healthy mom, a healthy child is most important for children's long-term health. And for a lot of patients, medications for opioid use disorder, like I talked about earlier, can give them that firm foundation to achieve recovery, to achieve that healthy lifestyle, that healthy living environment, being able to do all the things for themselves and their children that they want to do. And if medications are helping them achieve those goals, that is more important than the temporary condition of neonatal abstinence syndrome. However, NAS or NOWS is very important to recognize and is very important to treat when indicated because it can have some consequences physiologically for the infant after birth. Unfortunately, it's really hard to predict, though, which infants are going to develop NAS or NOWS, even if it's in a mom who is taking a prescribed medication like buprenorphine or methadone that is associated with NAS or NOWS. And it is really hard to predict if a baby develops NOWS or NAS after birth, how bad it's going to be. And that's because it's quite complex when people start looking into NAS and NOWS. And there's multiple factors that can affect the severity and the manifestation of NAS or NOWS. For example, we know that nicotine exposure has a dose-response relationship with the severity of NOWS. So for women in my clinic, for example, who are on Suboxone or methadone, who are also smoking cigarettes, we discuss a lot of smoking cessation strategies during pregnancy because I know that every little bit we can decrease on that nicotine exposure for the infant can also reduce the risk of the NOWS severity for their infant after birth. And so we focus on staying on their medication, buprenorphine or methadone, because it has established that it helps give them a firm foundation in their recovery. And then simultaneously working on decreasing the nicotine use gradually over time if the patient is at that point where they're able to do so. And so now we're going to transition into the 4th trimester, or quote unquote the postpartum period, which I argue is through 12 months after delivery. And what I really want to focus on here, and why this gets a whole section to the talk, is that this is when women are more likely to have the adverse consequences of opioid use disorder or substance use disorder, such as opioid overdose deaths. They are most commonly happening these days postpartum rather than during pregnancy. And substance use recurrence, so when people have the disease of addiction, they can have recurrence of their disease. Just like if someone has diabetes, they can have a period of time where their sugars are elevated, or hypertension where their blood pressures are high. Addictions just like that. There are ups and downs of the disease that do come. And this can also happen during pregnancy and the postpartum period, just like with any other chronic disease that we deal with. And so we know that women, even if they achieve abstinence of a certain substance during pregnancy, you see this is first, second, and third trimester, there is a subset that will have recurrence of that substance use postpartum. And so it's very important that we continue to support these women and recognize them and see what we can do to tailor our treatments going forward according to their needs, which a lot of times do change in the postpartum period with a new baby at home. And why this is so important is because this recurrence of substance use for postpartum women is killing women. So this is that same study I showed at the beginning of my talk, looking at overdose or drug-related and suicide-related deaths during pregnancy and postpartum, and how they had exceeded in Colorado causes of more traditional causes of mortality and morbidity among women, such as postpartum hemorrhage and hypertensive diseases of pregnancy. And you can see here, when these deaths occurred, most of them are occurring in the postpartum period, not during pregnancy. Some are, but most of them are occurring postpartum. And also, just as important, is that these deaths during the postpartum period are continuing through this 12-month period. They're not all in the first 3 months after birth. And a lot of these women were lost to care. They didn't come for their postpartum visit. A lot of them were not receiving treatment. So it's very important, what we need to do, it's very important to remember that substance use recurrence can occur postpartum, and it needs to come with increased support for women. And so we need to remember that increasing support comes in multiple different ways. We can't go over all of those ways today, but a few things I would like to focus on and how we can take action, how we can increase support, especially for women in the postpartum period. The first is with our language. So in my clinic, for example, I lead a clinic here for pregnant and parenting women with substance use disorders that is largely run by trainees that I supervise. And so I always instill in my trainees, we do not use the word relapse in my clinic. I know that's a little bit different, but we use the word recurrence. Substance use recurrence, we don't say someone had a relapse of their diabetes or a relapse of their hypertension. We say they had a recurrence of their disease. Their disease had a recurrence of the adverse consequence that can happen with that disease. And substance use and addiction is no exception to that. And we need to remember that the language that we're using in our clinics, with our colleagues, and with our patients can do a lot. And so using non-stigmatizing and person-first language can be very important to help increase that support and establish those relationships with patients so they feel not judged and they feel like they're receiving compassionate care. The second thing we need to remember is that medications for opioid use disorder for patients who receive benefit from them for opioid use disorder can save lives, and therefore can also keep families together. And like I showed earlier from the review paper from the Journal of Pediatrics, is that healthy living environment, a supportive family, keeping moms and babies together, those are the things that lead to positive long-term health outcomes for families, for children, and for mothers. And helping women stay on their medications through the postpartum period, not coming off of them after pregnancy or after delivery, is of utmost importance. And just to give one example of that, this was looking at overdose deaths in Massachusetts. The orange bar here are overdose events that happened for women who were on medication for opioid use disorder during that time period. And the gray bars are overdose events for women who were not on medications for opioid use disorder during that period. Even though this sample size is small and these bars all overlap, you can easily see the difference here, where there are a lot fewer overdose events in women who were on medications for opioid use disorder compared to women who were not. And so keeping women on, doing what we can to help women not feel judged for being on their medications, staying on their medications, keeping their Medicaid active, all the things is of utmost importance. How we do that though, postpartum, is very challenging. I'm not trying to pretend like it's an easy thing. I know this is the bulk of what I do clinically. My nurse and I, we spend a lot of time on these things. We spend a lot of time reaching out to patients. We spend a lot of time with harm reduction techniques. We spend a lot of time meeting women where they are. And we do that because the postpartum period is difficult. It is very challenging for many reasons from both the mom, baby, family side. And it can lead to gaps in their treatment. And we just saw in the last slide that having a gap in treatment, especially when we're talking about opioid use disorder and the medications that can save lives, gaps can lead to women dying and can lead to families being torn apart. So we're going to end on how we can all take action if I haven't given you enough ideas thus far. And we do need solutions now. Why do we need them now? Well, there's papers like this that just keep on coming out. This is another example. We've already shown the Colorado and the Massachusetts. This is the more recent one from Utah that came out last year, looking at their drug-induced deaths. And you can see here the drug-induced deaths with the black bars here, they shoot up in that postpartum period. And the most common substance that attributed to these drug-induced deaths were opioids, followed by other substances such as benzodiazepines and alcohol. And what is really sad from this paper is that they noticed that in general, over half of these women that died from a drug-induced death, for the most part in the postpartum period due to opioids, they were getting prenatal care. The average number of prenatal visits that these women who died had were 7. That was 7 chances for providers, healthcare teams, etc., to reach out to these people, to reach out to these women and these families where they were, to integrate harm reduction techniques, whatever it is in that moment. 7 chances per death that these women interacted with the healthcare system. Those were 7 missed opportunities that we could have done in these certain circumstances. And so what can we do to help fix this gap? Well, first is we need to increase treatment capacity, and we need to increase treatment capabilities, and we need to decrease the stigma and discrimination that women are experiencing when they do access treatment. And we need to increase our compassionate, person-centered approaches that help women stay in treatment once they're in treatment. This is data looking at the number of people who needed substance use disorder treatment, who received it. You can see here, this is 8%. And you can see here, this was over time between 2005 and 2014. It hasn't gotten better on a national scale. Less than 1 in 10 women are receiving treatment for substance use disorders that need it. Look in comparison to other chronic diseases that I mentioned throughout this talk. Diabetes, hypertension, even depression. We are down here. There is a lot of work to do. And when you look at among women, this is using NSDA data, unfortunately the numbers are not much better. So these are numbers down here of women who needed treatment for a substance use disorder who received it during 2007 and 2014. And this is just among reproductive aged women. We can see here that less than 1 in 10 women who needed substance use treatment received it. It was a little higher during pregnancy at 12.8, but even at that little higher during pregnancy, again, only 12.8%, okay? It was not statistically significant. So even pregnant women are still not receiving priority services, priority for treatment, despite being named a priority population with regards to substance use disorder treatment. And so the main action that I'm going to leave you with today that we all can take, no matter what your role is, if you are a provider, if you are a support person, if you are just a family member of a person who's suffering from the disease of addiction, we can all focus on decreasing treatment barriers through compassion, destigmatization, and decreasing stigma. And we know that stigma and these things that I just mentioned is keeping people from getting treatment. This is looking at men and women nationally in substance use disorder treatment of the most recent data, 2015, 2018. And having a negative opinion of treatment, okay, and being worried about the effect of that treatment on someone's job or reputation, and not having treatment options available, these were the top 3 reasons why people who said they wanted treatment and needed treatment did not get treatment. These are three major things that we can be focusing on, and no matter where you are and what role you're playing in this world. And so stigma and discrimination are really big, and they're big barriers, and they are especially significant when we're talking about women and we're talking about pregnant and parenting women. And I'm just going to leave you with some quotes from a qualitative research study that I did recently among my women who were on medication for opioid use disorder during pregnancy and the postpartum period. And what these quotes are getting across is that my patients tell me all the time, they will say things literally. I actually had a patient the other day tell me, you know, I'm doing the right thing, but I sure don't feel like I am. And people on the outside of this clinic are making me feel like I'm not. And she was referring to being on her medication for opioid use disorder, despite all the gains that staying on that medication during pregnancy and the postpartum period is giving her for her foundation of recovery. And so no matter what you do, no matter who you interact with, we can all work on decreasing stigma and decreasing discrimination for people that are suffering from the disease of addiction. And I strongly believe it is one conversation at a time. One conversation at a time on a one-to-one or on a group basis, and just providing education about the neurobiological basis of the disease of addiction. That little bit I gave you today, yes, you can have that discussion with someone. You can do it no matter who you are. I'm an OBGYN and I'm talking to you about the brain. You can talk to someone about, hey, it's not a moral failure. It's not a choice. There are multiple things that lead to someone developing this terrible disease of the brain. And there's multiple things both in the brain and in someone's environment too that lead to someone having sustained disease of addiction. And we need to do everything we can to meet people where they are, establish and integrate harm reduction techniques, be compassionate and non-judgmental to people who are seeking treatment. And we also need to increase those types of compassionate person-centered treatment programs, especially for women, and especially for women who are pregnant and parenting. Thank you very much. I very much enjoy speaking with you today. You're welcome to reach out to me via email. I'll be glad to speak with you. And I'll leave you just with a couple resources today on how you can take a stand on integrating person-first language and destigmatizing the disease of addiction. Is here at this free document here online with regards to person-first language and some online resources. Thank you very much.